I just want to make sure everybody's in. All right, everybody, it's 12:15, so I'm going to get started. Welcome to today's presentation. This is a 8-part series on designing graduate medical education in rural clinical facilities. And I'm going to be a little bit disjointed just because I'm welcoming folks. We are recording already. And I better let Lupe Alonso Diaz in because she's kind of important. Okay, some quick reminders about online meetings. I'm sure we've all heard this by now 1,000 times, but please be sure your audio is set at the appropriate level. Sometimes it's a low volume and you don't hear anything and wonder. Please keep yourself muted unless you are speaking. We will have a Q&A at the end of this presentation. The webinar will be recorded and then will be available on the same webpage that you registered at through cmadocs.org. If you have technical difficulties, it sometimes resolves the issue if you just log off and log back in. And with that, I'm going to start. My name's Christy Bird McKeeve, and I am the Executive Director of Butte-Glenn Medical Society, as well as the CEO of a new 501c3 named Healthy Rural California. And part of this webinar series came from our own efforts. Today, we're going to be talking about how the time is now for rural counties and communities to consider residency programs. And we are very fortunate to have Janet Kaufman, who is with UCSF and an expert on what's happening with GME in the state of California. We're very happy that she could join us today. In addition, we have Maggie Fassbender and Kiki Nocella, both of WIPFLE, who have been our partners in exploring what we can do, in particular on a psychiatry residency, and helping us set up now a GME consortium. So I hope you were able to take the quick polling questions that were in the entry to this webinar. So the series itself has been in progress. We're sort of in the middle of it. And Happy New Year. In September, we recorded the first webinar, and it wasn't necessarily in chronological order of any particular content, just sort of the way that we spread it out over time. So the first was really about how GME partners are a 2-year journey that, when you're talking about an academic affiliation, it just can't be, a shaking of hands and it gets set up. It does take a long time, and as Kiki described it in that webinar, it's more of a marriage of sorts. So, and these, I'm just going to go quickly through. They're already recorded and available on the CMA Docs website. In October, we recorded feasibility studies and business plans. Why are they important? What do they do? And how they are, they do cost some money that you have to pay for. State efforts to expand residency programs was in November. And then in December, we had the, what's latest with ACGME requirements. A lot has changed in the last 5 to 10 years. And knowing what a resident would expect from a program helps you design a more effective and sustainable program. The time is now is right now. The time is now. That's today's webinar. And then coming up at the end of January, expand or create new, that is the question. In February and the 25th, we'll really go into greater detail about what we have been doing with Butte-Glenn Medical Society and now Healthy Rural California since the campfire in late 2018. And I haven't really put that panel together yet. Dr. Andy Miller is on this call today. Dr. Miller, it would be great if we could sort of put a panel together to talk about how we learned a lot from the campfire in Butte County and how that really affected our access to care issues and why we then struck out on the path to create residency programs in the area. And then in March is about board certified physicians and why they are important for residency programs. Again, that's the link there of all of the recordings, future registrations, as well as these awesome primers that the Physicians for a Healthy California team have been putting together following the webinars so that you can have a PDF at your fingertips to share with your teams, whatever you're planning to to bring together as a group. Maybe it's a consortium that you're building. The PDFs give really short, sweet summaries of what you need to know. And really, these are all things that I wish I had known more than a year ago in the summer of 2019 when Butte-Glenn Medical Society embarked on our residency task force. So a huge thank you to Physicians for a Healthy California. Lupe Alonso Diaz just joined and is on the call. Good to see you, Lupe. Paradise Medical Group also helped sponsor this series. California Medical Association, who is also our partners with Butte-Glenn Medical Society for membership. And then, of course, our residency task force. I'm not going to go into these tips because I've covered them in greater detail in the prior webinars. I also have on our Butte-Glenn Medical Society YouTube channel my own description of what had been happening through, I think, September 2020. And I need to maybe update that soon. Just know that establishing a residency program can cost $1 million or more. It's extensive. It's a lot of coordination between a lot of different organizations, and it can take much longer than anybody would ever even imagine. So those are some quick tips. They're also available, I think, on the summaries that we print. So I'm going to now introduce Dr. Janet Kaufman and give her the chance to load her slides while I give a brief overview of what I've learned. She focuses on building bridges between academia and policymakers. She's a professor with the Institute for Health Policy Studies. I first got to meet her in a recent presentation that was national through the AMA, and was really impressed hearing about just her knowledge of what's happening in California with GME. One of the facts that popped out at me was that there are much more internal medicine residents in the area, and what that could mean if you're considering starting up a residency program in your area. So Janet, you're welcome to share your screen and let me know what you need.
Okay, great. Thank you very much. Things froze earlier, so that's why I popped off and popped back in. So hopefully that will not happen again. Let's see, let's go to slideshow. Okay, and this is the slideshow view, everybody?
Perfect.
Okay, great. Well, thank you very much. So what I'm going to do today is largely talk about the physician workforce and medical education landscape. In talking with Christy, you know, I got a sense from her that it would be valuable to give you sort of a 30,000-foot view to kind of, any of you who are thinking about starting residency programs or actually starting them, you know, sort of the context within which you're working, and then maybe end with, you know, sort of a few recommendations. I don't think any of them will be a surprise for you all. What I'm going to start with is trends in medical school enrollment. Not going to spend a lot of time there, but I think that's important because that's sort of the inflow, the inputs, if you will, to residency programs. Then spend some time on current supply and distribution of residency programs and residents by specialty and region. Talk some about our current physician workforce, you know, what's the workforce into which our residents are flowing, and what are its strengths and limitations, and then just briefly about a few opportunities for aligning GME with physician workforce needs, topics that you're going to go into much more depth on in subsequent sessions in this series. So medical school graduates, what is happening with medical school graduates? I thought maybe before we go there, is it's important perhaps to do a diagram like this to kind of understand how we get from medical school to practicing physicians in California. So in California and in all states, there's really three groups of medical students who come into play. There are those that graduate from medical schools in our own state. And we now have 6 public MD granting schools, 5 private MD granting schools, and 3 osteopathic schools. Then there are medical schools in other states. California has far more applicants to medical school than our medical schools can accommodate. And a very large proportion of Californians are educated out of state. And then we have international medical graduates who come to the US for residency. And so folks from any of these three types of medical schools may do a residency program in California. They may do a residency program in another state and then flow from there into practice in California. Now, those who do their medical school and residency both in California are the most likely to practice in California, but the other groups do practice here as well. I think particularly an important subgroup are the Californians who attend medical school elsewhere, but have always had the intention of coming back to California to practice. I think you see some of those folks be very strategic about where they apply to residency programs to maximize the likelihood that they'll match into a California program. So where are we? And this is just to show you of our physicians in California, where they come from in terms of medical school location. So about a quarter, 24% or so, graduated from a California medical school, 48% from other states, 28% internationally. And that's a fairly typical of most states. So looking at trends in medical school graduates in California, this slide plots 2003 to 2018. And the blue are MD, graduates of the MD granting schools, and the gold are graduates of the DO granting schools. This goes only through 2018 because that's the last year for which I have the osteopathic data. And what we do see is when we get to this end of the period in 2018, we've seen a fair amount of growth in graduates. What you don't see on this slide is what's going to happen as we go on out from 2018. And that is because these don't capture data from two of the new private MD granting schools, and that would be the California Health Sciences University down in San Bernardino County and the Kaiser Medical School that just opened in Pasadena. They also don't capture the new osteopathic medical school in Fresno. So this is going to go up even further. Charles Drew University is seeking to expand to being a 4-year medical school, and if they're successful, that will expand further. If we look at the US, we can see that the US overall is actually ahead of California in this ramp up in number of medical school graduates. Again, the MDs are in blue, the DOs in gold. And there's been this growth, and particularly among DO schools nationwide in number of graduates. There's been growth in residency programs as well, but not quite at the same level, at least for those programs that someone would typically enter right out of medical school. And so there's actually been some increased competition for residents, which may be a good thing if you're looking to recruit and start a new program. So now with that sort of context, let's move to GME in California. And some key points here: the number of residents and fellows has grown over the past 15 years. Internal medicine programs account for the largest share of positions filled in the match. And I think many of you are familiar with the National Resident Match Program. If not, we can clarify that. Our residency and fellowship programs are concentrated in urban regions of the state. And as we'll see a little later, those are not necessarily the regions that have the greatest need for physicians. Rural areas have greater need. And then lastly, California has the highest rate of retention of residents following graduation of any state. You know, if we can train them in California, they're highly likely to stay. So this is a plot of numbers of residents from 2006 to 2018. And this is really looking at the allopathic programs. This is prior to the shift that's occurred with combining in allopathic and osteopathic residencies. But over this period, about 12-year period from 2006 to 2018, number of residents grew from about 9,400 to 11,600. And dividing these residency programs, one way that the ACGME looks at this is to distinguish specialty and subspecialty programs. So what does specialty mean? So let's take the internal medicine example. A general internal medicine program here would be classified as a specialty program. A cardiology, cardiology, gastroenterology, rheumatology, you can think of all the subspecialties of internal medicine, would be a subspecialty program. Now, to be sure, there are people who complete an internal medicine residency program and then go on to practice as an internist, but some of them do then a subspecialty program. And then you have other specialties, family medicine as an example, where yes, there is some subspecialty training, but a lower share of folks get that subspecialty training. More of them go out and practice as a family physician and don't go on for further GME. And then this is just looking at those percentages and converting to numbers of graduates per year. So number of people who complete their residency and are ready to either go into practice or transition to subspecialty training. So in the academic year 1920, we had 2,802 graduates of specialty programs, people who had completed the requirements for board certification in a specialty. And then we had 1,266 complete subspecialty training. Now you might look at that and think, well, how is it that there are so many subspecialty grads if they're only 18% of the total? Well, remember, subspecialty training is usually relatively short, 1 to 2 years, whereas training in a specialty typically runs anywhere from 3 years to 5 years. And in something like neurosurgery, it may well, I think, run longer than that. And so you just have fewer people graduating each year because your program is longer. Does that make sense? Okay, so this is looking at where our residents come from in terms of the types of medical schools that they attended. And this one does not, these data from the ACGME don't split out they don't split out California versus not California. The data I showed you on practicing physicians by med school location is from the Medical Board of California, where we know the name of the medical school, and our team has done our own classification. Here we pulled this from ACGME. And so we see here 77% of our residents in California are from an MD granting medical school somewhere in the US, some in California, some others in other states. 12% come from US osteopathic medical schools, probably a little lower here than in some states, because even though I've told you that we have 3 osteopathic medical schools, historically we haven't had as much osteopathic medical education relative to allopathic. And then we have about 11% international medical graduates, and that's lower than some states. If you go to the New York metropolitan area, Chicago area, significantly higher percentage of IMGs. So looking at what specialties are residents training in, the ACGME breaks the specialties up into 3 big buckets. And one is hospital-based. So think of things like emergency medicine, anesthesiology, pathology, where practice is typically done in a hospital inpatient or outpatient department, and it's often episodic. You may see the person multiple times in the ED, but you're not their continuity care provider. If you're an anesthesiologist for a surgery procedure, you may never interact with them again. The biggest group, so that's about 600 in hospital-based. The biggest group are those that are in medical specialties. That's almost 2,000. And again, this here is not medical subspecialties. This is those specialties in which the care is medical, say, instead of surgery. So in addition to internal medicine and pediatrics, this would be things like family medicine, dermatology, psychiatry is here, which no disrespect to any psychiatrists in the audience, probably seems a little odd, but that's how ACGME classifies it. And then the last would be the surgical specialties, 480. This would be general surgery, orthopedics, plastic surgery. In this classification system, obstetrics gynecology is considered a surgical specialty. So your OB-GYNs are there, whereas your family physicians, internists, and pediatricians are in medical. And then looking here, those data I just showed you are kind of sort of all residents. These are data from the National Resident Match that occurred last March 2020. And looking at how the 3,233 physicians who matched into residency programs in California are sorted out across specialties. And the largest by far is internal medicine, 947. And, you know, that's a mix of those programs that are primarily geared to preparing people to go on to subspecialize, and those programs that are really focused on primary care internal medicine. Then we had about 500 in family medicine, and then going on from there, about 278 in peds and 229 in emergency medicine. I just made other sort of this big grab bag, you know, for the number of bars we could put on the slide. But that gives you a sense of where folks are starting out, at least on their path of residency training in California. I want to talk now a bit about geographic distribution of residency programs. And here I've selected internal medicine because it is, you know, the one that has the most first-year residents. And so I've sorted the state here into about 9 regions. These are regions that are used for the California Health Interview Survey. They're regions that our team uses a lot when we look at health workforce data. And I think one of the key things I want to call your attention to is right in the middle, the Northern and Sierra region. Butte and Glenn County are part of that region. As of last year, you had no internal medicine residency programs. Now, there are some family medicine residency programs, you know, Mercy and Shasta Community Health Center over in Shasta County, new ones in Humboldt and Ukiah, but just really thin on the ground. You know, conversely, look over to your left, Greater Bay Area, Inland Empire, Los Angeles County, 8 to 10 programs. Other areas, Sacramento area, and this was a little surprising to me that you've only got 1 there. And then you see places like the Valley, you know, more programs than Northern and Sierra, but still, you know, significantly less. So I think this tells us that, you know, where is there opportunity for growth? Yes, it is in more rural and agricultural parts of California. This is a different way of visualizing data. This is a map of California with red dots to indicate where the psychiatry programs were as of 2019. We will soon, hope, you know, not next year, but soon see a dot in Butte County for that. But just at this point, again, no psychiatry programs north of Sacramento. There's, as of now, nobody in training north of Sacramento. There's really nobody in training on the Central Coast between San Jose and Los Angeles. And there are a few programs in the Valley, but not many. And nobody training in Imperial County or the Eastern Sierra either. Again, I've only, for the interest of time, I've only plotted out internal medicine and psychiatry. We have the data. If folks are interested, we can plot some of this out for folks who are interested in other specialties. And then this is my document my retention comment. Here I've arrayed California, Florida, New York, and Texas. And the percentages indicate the percentage of people who completed a residency in that state who remained in the state to practice. And we see California 71%. That's the highest in the nation. And I picked these 3 states because they're the 3 next most populous states. And you see they range from 45% to 59%. Now in New York, it's possible some of those folks trained, let's say in New York City, and then are practicing in the New Jersey or Connecticut suburbs. And maybe you could argue that they're still kind of local, but I don't think that would add up to 71%. percent. So again, if we can train them in California, we tend to keep them. So now let's move on and look at the current physician workforce in the state. And I'm going to try to speed up a little so that we have plenty of time for discussion. So the last data that our team has tabulated is from January 2020. We have some funding from the California Healthcare Foundation to update our work on the physician workforce, and hopefully the publication on that will be coming out in February. So as of January 2020, California had about 107,000 physicians practicing in the state who had completed their residency and fellowship. So folks who are done with training. And of these, about 88,000 provided patient care at least 1 hour per week. Well, you might say, well, what's going on with the other 19,000? Well, some of them are doctors who are retired but still maintain their license, and maybe they do some volunteer work, but they're not, actively, in practice, during the week. There are also physicians who are, say, medical directors who really aren't doing patient care, people who are, say, working for pharmaceutical companies or doing bench research where they just don't do patient care. Some who are maybe doing things like teaching health policy where they're no longer touching patients. But anyway, that's where those folks are. So 88,000 providing patient care at least 1 hour per week, about 75,000 providing patient care at least 20 hours per week. Our team tends to focus on this last group because that's the group for which patient care is really a big part of their professional activity and their professional work. So then let's take those active patient care physicians, those working 20 hours or more per week, and array them by specialty. 31% are in primary care. Now, folks define primary care various ways, but for these purposes, primary care would be family medicine, general internal medicine, general pediatrics, and geriatrics. Some folks, consider obstetrics gynecology primary care. I think you can argue that. If you look at what they do, a fair amount of it is primary care. If you look at how you're trained, I'd argue they're a surgical specialty. But anyway, 5% OB-GYNs, 6% psychiatrists, 2% general surgery, another one to pay attention to for rural areas. And then the remainder are facility-based specialties, which are analogous to what ACGME calls hospital-based specialties, medical specialties, surgical specialties, and about 2% we're calling other because they're in things like aerospace medicine, undersea medicine, things that are hard to complementary alternative, things that don't neatly fit into another bucket. And that should be 2020 data. I forgot, that's 2020, not 2015. I forgot to update the year. Turning again to our theme of geographic distribution, ratios of physicians per capita vary widely across the state. Rural and inland regions have lower supplies per capita than urban regions. And I'm not showing a slide here, but I do think it's important to note that even in urban coastal regions, some low income communities have shortages. That physician supply, if we take Los Angeles, looks very different in South Central than it does in Beverly Hills. So this is 2020 data on ratios of primary care physicians and specialists per capita in the different regions of California. And then down at the bottom, I have the state as a comparison. And we do a lot of this looking at ratios per population so that we can make kind of apples to apples comparisons across regions. Los Angeles County has something like 25% of the state's population. Much smaller land area than, say, the Northern and Sierra, which covers all the counties north of Sacramento, kind of along the spine of the Eastern Sierra. Much smaller land area, but many more people. And so if we're going to compare those areas, we really need to put it on a population per population level to be meaningful. And so we see here the areas of the state that have the lowest supplies of both PCPs and specialists per capita are the Inland Empire, San Joaquin Valley, and Northern and Sierra. This is no surprise. I've been looking at physician workforce data for 25 years, and 25 years ago, those were the same regions that had the lowest supplies. The highest supply specialists by far in the greater Bay Area, as well as the highest supply of PCPs. And then you see other urban areas, not as robust a supply as the Bay Area, but certainly more robust than the more rural areas. Okay, age distribution. This is important for us for understanding, how many of our physicians are at or near retirement age, how many are going to need to be replaced within the next 10 years or so. And so I think a key thing here, 19%, that's almost 1 in 5 of our docs who are providing patient care 20 or more hours a week is over age 65 or older. So 1 in 5. And we haven't broken this down. I didn't break this down in rural areas to show you, but if we looked at rural counties, if we looked at Butte-Glenn County, it's even higher, probably closer to 30%. Just a little bit about race ethnicity, since we are such a diverse state, both in our rural and urban areas, is that our physician diversity doesn't really match the population. Black and Latinx and Native American physicians are underrepresented among physicians relative to their representation in the workforce. Now, one thing I didn't do here that might be of interest in Butte-Glenn is I didn't break out Asian Pacific Islanders by particular Asian Pacific Islander ethnic group. Full disclosure, I have relatives in Sutter County, and Sutter certainly, as some of you who've been in Sutter County know, has a large East Indian population, and some of the other counties may too. So I think certainly folks in Sutter might want to be able to look at that. I will say though, generally East Indians, Pakistanis tend to be pretty well represented in the physician workforce, in part that they'll come here, that there are folks who come here, have been educated in India and come here for residency. Future supply and demand for physicians. I'm not going to spend a lot of time on this because I think we want to move to discussion. But this is some work we did a few years ago that we're in the process of updating, looking at supplies of primary care clinicians. And here we're looking at primary care docs as well as nurse practitioners and physician assistants. I think the bottom line here is, unless you believe our high supply projections, which we think are unrealistic, we are probably looking at a shortage of primary care clinicians by the year 2030. And the high supply means that we're really growing NPs and PAs at really high rates, as well as expanding residency programs for physicians faster than we've been doing. Psychiatry, this is a little more complicated, but let's look over at the right-hand side, 2028, our projected supply of psychiatrists of 3,833. And our two scenarios for demand. One that's, what would it take us to maintain current use of behavioral health services? And then the second, what would it take if we maintain current use and met unmet need? And Christy, I think, is cringy, and it is. Is a disaster. And this is why I have been saying for people for several years, yes, we need to do more in primary care. Primary care is tremendously important, but psychiatry, mental health in general is the place we really need a strategy. We need to do more, and whether it's standing up new psychiatry residency programs, expanding, or thinking more about how we cross-train in primary care and psychiatry. So just real quickly here, I think these data make the case for expanding GME in primary care and psychiatry across the state, in rural and inland regions across specialties, but I would say particularly primary care and psychiatry in rural areas, because they're really the linchpins. And I think if one of the things this pandemic has taught us is just how important behavioral health services are and the need for those, and that psychiatry in some ways really is primary care for folks with those needs. Also want to think about establishing new residency programs in GME naive hospitals and other settings as you're doing in Butte. And also, then again, getting more creative about non-hospital settings. We've had funding for some years for teaching health centers. Shasta is a great example of that, small program, but a great example of a community health center-based residency program. On the behavioral health side, San Mateo County has run a psychiatry residency program for years. I mean, they do partner with other, with hospitals. And yeah, that's suburban county, but still it's a model of the county behavioral health department driving the residency program rather than a hospital, and a program that provides a whole lot of opportunity for residents to engage in the public mental health system where they're most needed. So I think I just want to say briefly, thanks to my collaborators. No one does this work alone. And in fact, that's just my current collaborators. They're folks on Kevin Grumback and Andy Beinman, who've been my mentors for 25 years. We no longer work on this together, but I learned tremendous amount from them. And our funders, including Physicians for a Healthy California, UC Office of the President, and the California Healthcare Foundation. So I'm going to stop there.
Thank you so much, Janet. I know that Dr. Andy Miller has 2 questions and he has to go soon, so I'm hopeful
Sure.
in the floor.
Yeah, thank you so much, Janet. I'm sorry to jump to the head of the pack, but I do have to run here in just a minute. I had 2 questions. If I had more time, I'd probably think of more. But the 2 that I passed along to Christy are the relative strengths and challenges of choosing an internal medicine versus a family practice residency pathway for a rural community would be one. And the other was whether you have seen the creation of a new FQHC along with the creation of a new residency in the past, and what your thoughts are on that.
Okay, so why don't I take the first one because it's a little short. The answer is no, I've not seen the creation of both a new FQHC and a new residency program simultaneously. The teaching health centers that I'm familiar with have all been part of established community health centers. So Shasta, for example, been around for a long time. In fact, historically had partnered with Mercy on a residency program before they went to sign their own. So I think, is it doable? Probably, but we don't have, at least in California, I'm not aware of a good model. Maybe someone else is.
Yeah, and just so you know, I went through the Mercy residency program. I was one of their graduates. So.
Okay. Well, and now again, you're not in Redding, but you are at least up in rural Northern California. Okay, great. So now family medicine versus internal medicine. I would say it depends a lot on what are your local needs. If your local need is primary care, family physicians are your most versatile primary care providers. They have preparation to care for people of all ages. They have, preparation to do low risk obstetrics, women's health care. So I think if that's your need is primary care. If your need is subspecial, like I say, if your need is medical subspecialties, if you're in a community where you're struggling to get, let's say, enough rheumatologists to care for people in the community with rheumatic disease or cardiology, whatever it might be, then having an internal medicine program that, enables folks to get that foundation to do subspecialty training, that might be the way to go. The other reason you might go internal medicine is if you're in a rural community that has a high proportion of seniors in the population. Internists I think it's fair to say that internists, because they're solely focused on adult medicine, they do, I think, a little more intensive hospital, care with acutely ill, that they're, I think you can make the case that they're better prepared to care for seniors. Of course, both family physicians and internists are better prepared to care for seniors if they've got some training in geriatrics. If not a geriatric fellowship, then at least a real strong module in their residency program and some continuing education on how to provide the best care to older folks, especially, and not, thinking not just your average 65-year-old, but your 85-year-old who's in the nursing home with multiple challenges.
Thank you. Yeah, so I guess maybe a slight follow-up. Part of the reason for the question is wondering the unique challenges. So for family medicine, as you mentioned, you have to do OB training. And so there has to be an OB pathway within your hospital and community to get that training, which in a way makes it a little more difficult than an internal medicine. So your answer was driven primarily by the needs of the community, which is a good way to look at it. But we also have the challenges of what we can step up and get done.
Oh, absolutely. And that's maybe sort of the second leg is, well, what's feasible in our community? And if you don't, certainly if you don't have local hospitals that are prepared to be a partner in OB, internal medicine may well make more sense. I would just say if your goal with internal medicine is primary care physicians, then you need to be really thoughtful about designing a primary care internal medicine program and being strategic about recruiting residents who really do want to become primary care providers, because on average, you know, folks who go through internal medicine residencies are much less likely to stay in primary care. But there are, but again, there are examples. It's just be really proactive.
Yeah. Thank you, Janet.
Are there any other questions? I see that, oh, somebody's still joining. Kiki Nacella just joined us. Hi, Kiki. Okay. We have a lot more participants this time, so I'm hopeful. Anybody else have questions while we have Janet available to us?
Hopefully I haven't overwhelmed you with data.
No, and I love how you present the data so that somebody like me can, you know, understand it all and see the big picture of it. Very, very helpful, as Dr. Miller was just describing, just, you know, figuring out what our next steps are. So we are creating a GME consortium that can house other residency programs, starting first with psychiatry. So it's very much a part of our conversations as we're doing psychiatry about what comes next. And years, I mean, Dr. Miller actually described and introduced me to somebody who's been trying to do family medicine residency programs in the area. So both psychiatry and these other primary care residency programs have been discussed and needed and wanted for more than a decade. And yet the ability to turn that goodwill and that interest in the great healthcare that's in the community into a residency program is really tough. So you gave us a lot of data that's helpful. Thank you.
Okay. And I do think it is, you know, to me, I was delighted to hear that you're, you know, starting with psychiatry for the reasons I talked about, but also that I think having a psychiatry residency program there in the community, if you were to also stand up family medicine or internal medicine, is then you have that psychiatry program to be a great resource for behavioral health training for your primary care providers.
So I spent the last week before Christmas applying for an ACEs Aware grant. It's a plan grant, hopefully, that we could get. I'm not quite sure it's fully aligned with their granting expectations, but it would be for the GME consortium because we really do want to have trauma-informed care embedded in first psychiatry and then whatever follows. And that's going to be the defining factor of our GME consortium.
Okay, I see we have one question in the chat. Let me pull that up. So this is from, and I'm going to apologize if I butcher your name, John Abimandam. So regarding international MD applicants to California GME, what's the possibility of work visa sponsorship that was required for many applicants in order to pursue residency? Kiki, is that something you could take? I'm not an expert in visa.
Boy, I was hoping to stay away from that one and turn that to you. I'm not an expert either. I will say that with smaller groups, startup groups like what we're talking about in Butte County, I tend to recommend they not do folks who need work visas right away because there's a whole infrastructure that needs to go with that. Now, if it turns out that one of the hospitals is hiring the residents, or the county is hiring the residents, none of which have been defined yet for this consortium, then they may already have the infrastructure. And so this is one of the things that we look at in setting it up is, you know, who has that infrastructure, because we definitely don't want to recreate it. So that's the best I can offer at this point.
And I think that's about what I would say too, is that, you know, there's a lot of involved, and you want folks who are, if you're going to go that route, you want to have folks at the hospital or somewhere local that really know the ins and outs of it.
I'm laughing because there's two topics in the world of residencies that when I hear them, I go, nope, not going near it. And visas are one of them. So good job asking me the questions that I hate touching.
Okay, well, any other questions? We're going to wrap up in a few minutes otherwise, and just thank you to Janet for joining us and sharing this great information. We'll be in touch and keep you informed of what we're doing. Just have to get over a little hurdle. And this goes into what I was saying in the beginning, which is that it takes more resources than you can ever imagine. We are trying to raise 1.1 million in order to get to accreditation for psychiatry by fall 2022, at which point, when accredited, a $1.8 million OSHPD grant will then flow to the psychiatry residency and get us to the point where we will become self-sufficient and moving forward. So not only did we raise 1.8 million, but now we're in the process of raising 1.1 million in order to get the 1.8 million. It's been incredibly challenging, but I will state this for anybody on the call that's not familiar with this. A lot of the sponsoring institutions end up being the medical schools, and we've chosen to create a consortium through Healthy Rural California. And so when you're dealing with a medical school, they have all the resources and the staff to get to accreditation. So state funding would be set up so that you have that goal and the funding goes to the academic institution and they're able to absorb all of that. But when you're creating a new consortium, which is a very valid way to set up a residency program, the funding mechanisms don't necessarily flow the same way. So that's our little world that we're in right now.
Let's see. Okay, I think that's Maggie. Thank you for following up with Dr. Mandam about ECFMG J1 sponsorship. That's a good suggestion.
Okay, well, thank you everybody for joining today. Please be sure to go to the cmadocs.org website with /GME webinars. We continue to post the recordings of these webinars as well as primers, which are PDFs that you can download and use as resources. Thank you, Janet.
Oh, you're welcome. My pleasure.
Good to see you, Kiki. Happy New Year. Oh, thank you, Maggie.
Thank you very much, Christy. Thanks, everybody. Bye-bye.
Good to see you all. Take care, Janet.
Bye-bye.
Bye.
Kiki, I do have a quick update for you.
Okay, cool. I was going to call you, but we can do it this way too.
Yeah, I have another call, but probably 1:15 is fine.
Yeah, nothing quite like joining a presentation in the last 3 minutes and that's the question you can't answer.
Wrapping up. Oops.
Sorry.
Okay.
I've got to get control of my calendar.
No, Kiki, it's not possible in this environment. It's like, because it's Zoom, it may, or it just, everything goes out the window. Like, when you have to schedule time to go to a meeting, it makes for a more structured thing.
Yeah, but when people go on your calendar and book things that you have to do, and it's like, wait, who thought that was okay? So yeah, that's what happened today. So I apologize. So do you want me just to give you a buzz on your on your cell?
Yeah, that'd be a good idea.
Okay, cool. I'll give you a buzz right now.
All right.
All right, bye.
Bye.